really encourage them. And I think you've been on the attorney board. I think you see a mom who's breastfeeding, and she's in a zone, right? And she's just looking at that baby. You can talk to her all you want. She didn't hear a word you said. You know, she's breastfeeding the baby. She's totally there. You can't even put a value on that. You know, her attachment to that baby, what it's doing to her self-esteem, it's probably one of the strongest things to build her self-esteem that's ever happened in her life. And she feels worthwhile. She feels wanted for probably one of the first times in her life, other than someone who wants to have sex with her and have her babies, and her have his babies and stuff. So to me, there's a sociologic event happening there that can probably solidify a certain number of moms' recovery that wouldn't otherwise happen. It's worth it to me, what little gets passing through the breast milk. But I don't know if that helps you, but we strongly encourage, it's unusual that they exclusively will breastfeed through that 5-day observation. It is so stressful. They're under a huge microscope to do everything right. And just that they're asked to do the scoring along with the nursing staff, depending on how the nurse approaches that whole thing. Moms feel like if they didn't get the same score the nurse did, they failed. They didn't do it right. And some of them even have the fear around the scoring that they'll elucidate. The biggest fear they have is DHHS is going to swoop in and take that baby. So just being sensitive to the space that they're in and leaving the judgment at the front door when you come to work and just accepting whoever they are without a lot of judgment. Oh, they're really manipulative. Oh, geez, what am I going to do? Right? You hear that? Those sort of voices, and it's about me. And I think it takes a certain level of, you have to get up to a comfort with yourself to be able to do that. Okay.
Coming back to your judgment comment, after going through the Snuggling series and listening to Mark Moran talk, who was the social worker that we worked with pretty closely,
yep.
He was saying how, just what you said, the judgment needs to be left at the door because they are so scrutinized in what you were just saying, during the scoring, how did they become addicted? It may not have been their choice to use drugs.
But it wasn't at the same level that you and I make choices.
Right.
But how much insight they have and how they climb out of that pit and stuff, yeah. And I'm not making excuses. Right. It's more just as caregivers that we have contact with patients, trying to understand where they are, what place they're in, and really seeing. I think there's someone who defined love, and I liked it. And this is how you sort of approach other people, is seeing, love is seeing others as such. Okay? So love is seeing others as other and not something that has to do with me. So in your work, dealing with patients, seeing someone else as such and not something that gives me, oh yeah, I did a good thing, or yeah, that was really good. Being able to rise to a higher level, and you're not going to do that like you turn on the light bulb and stuff, but it's just thinking about it, and maybe I planted a seed that some of you can let grow.
And I think through some of all of the students, but Emily's comment a while ago about when mothers come in for prenatal care, do they readily disclose about the illicit drug use? I don't know if that was a preconception of all the students here thinking that that's what we were talking about, was, are we just dealing with this population that are illicit drug users and don't want it disclosed, and all of a sudden you have an NAS baby? And I think we are learning from this that no, that's not the general population. There are people that are going through treatment for 9 months. And
think, you see moms who delivered and they worried about the Tylenol, they took it.
Yep. Yep.
You also, another behavior I see a lot in moms, they may not be in a medication-assisted treatment with Subutex or methadone, but they will get street methadone when they're pregnant, or street Subutex, because they know that's what moms who are pregnant get. Yeah. Not that that's what we want them to do.
No, but it's
Because
the
still-
reality
yeah,
of what.
It's still that cycle like that. Now this is all about me trying to get through this, right? And I should just stop and see what other questions have come up. Right. All right, the genetic stuff. Let me just leave the genetic stuff. We've done this, we published it. We looked at, they call them single nucleotide polymorphisms, but they are small DNA changes in proteins that still allow the protein to function. It just doesn't function the same way. So we know that in adult studies, that have been done probably over the last 10 years, that 40 to 60% of the risk of developing addiction, of the risk is genetic factors. The other three are some reason to abuse, so and ACEs, and then the other one is the regular use. So those are the three things that produce it. And the regular use is what suppresses your endorphins, your endogenous opiate, and really kind of gives you brain damage. All right. So we looked at babies that we were taking care of in 2 different cohorts. It ended up being 86 in the second cohort, 26 in the first one. We did this along with Tufts. Most of all of this was saliva, and we looked at the ones I'm going to show you are just the receptors. So the mu opiate receptor, and sometimes if you read about it, it's called OPRM. So the opiate receptor, mu, and the M's for mu. But the mu receptor, what we found was pretty significant, was that the treatment rate for this particular allele, which is the most common, we found the treatment rate was 72% in the babies that had this particular genetic makeup, as opposed to this particular genetic makeup, then there was only a 50% treatment rate. So I'm going to not bore you with all the other details about SNPs and the different, what these different alleles mean, but it's just that we validated that which babies get treated, and this babies don't have ACEs, but which babies get treated depends a lot on their genetic makeup. So it's probably about a 50% difference on which babies get treated on what their gene package is. Now, where do they get those genes from?
Are you saying that?
Moms and dads, right.
That if you, that you do genetic testing on all the babies that came in, and then these 72% you would not treat, opposed to 48% you would treat?
We did treat. So these babies got treated.
So everybody got treated?
No, just these babies. These were babies that came in through the door that were part of another study that had to do with the long-term developmental outcome. So we looked at a sample of the total population. We have a grant in now to do the whole population. But that, what I want to show you is just that genetics drives the treatment rate of babies, as well as it's already been shown it drives the addiction potential for moms and dads. But it also drives which babies get treated, as well as whether or not we use a second medication in those
So
babies.
this was more successful, this allele group was more successful in treatment than this?
This one, we only treated half the babies, the other half went home without treatment. So this is we observed half the babies, they didn't need treatment. Here we observed 25% of the babies, and they didn't need, and whereas 75% of babies were treated. So more often, if you have this allele, you're more likely to, if you're opiate exposed in the pregnancy, you're more likely to be treated. Is that okay?
Yeah.
You guys with me? All right. You guys got to get on this cutting edge stuff. You know, right? No, this was in JAMA this last year. So I figured I'd let you, and we're also looking at some other stuff currently. So, response to treatment, mother's opiate exposure, methadone is more likely to be treated than prescribed opiates, and buprenorphine in between. Breast milk favors a decreased treatment rate. We did better with methadone on methadone-exposed babies and your genetic makeup. So there's a lot of variation in the response to treatment. One of the things that was unexpected that we found out of the database, that the risk of prematurity is twice the main rate for methadone-exposed, the pain medication-treated babies, and illicit treatment. Here's the graph. Here's the main prematurity rate in 2009. 10% prematurity rate for everyone that are pregnant in Maine. That's about 12% for moms on Subutex. It's about double that for moms on methadone, and about double that for moms on prescribed opiates. We know that moms who are using illicitly really go through that intoxication withdrawal cycle. Remember how we were shown that twitchy uterus, the blood flow? We can understand that. I'm not able to really give you a good reason why moms, two groups of moms in medication-assisted treatment, one group has twice the prematurity rate than the other, and they're both on long-acting, so they're not going through that cycle. They're in long-acting medication-assisted treatment. And these moms on prescribed opiates, I think they're shorter-acting. Like any mom, worry about that Tylenol they took at 20 weeks. They worry about exposing the baby to opiates, and they probably try to cut down a little bit. So I don't want to expose the baby to opiates. They'll be less likely to withdraw, right? No, not right. But it's just that thinking, trying to do what's best for the baby. So I share that with you. So we looked at that. Here's what we've covered, including then treatment and sources of variation. We start out with addiction, adverse childhood events. We had that continuum of care. I showed you our numbers, and then talked about screening and scoring. Here's some factoids to take out of here. It sounds like somebody from outer space. See, I had that, somebody used that term, factoid. What? It's a factoid. So these are, that birth weight is in a slightly lower percentile for opiate-exposed babies. However, the head circumference is preserved in the same percentile as the birth weight. So we're not getting small-headed babies out of all this. All right, that's the same. And developmentally, we were just talking about that. Developmentally, what we're finding is that if you can isolate opiate exposure, it doesn't impact neurodevelopment. It's just that there are other mental health issues or other drugs of abuse, particularly alcohol, that will contaminate the whole outcome number, because alcohol is a very potent teratogen to the developing brain. So it really will decrease neurodevelopmental outcome. And it goes along with some people who are in medication-assisted treatment or with opiate abuse. Treatment rates, length of stay are higher with methadone than they are prescribed narcotics. Breastfeeding associated with lower treatment rates. Illicit drug use is associated with younger mothers, lower gravity, so lower age and higher rate of prematurity. Treatment withdrawal with exposure to methadone responds better to treatment with methadone. Prematurity rates are higher among moms on replacement medications, prescribed opiates, methadones, and methadone is equal to narcotics, and it's also higher than buprenorphine. And their inheritance of at-risk genotypes that are associated with addiction, also explaining a large portion of variation in how babies respond to treatment. So at discharge, we've done a lot of work in the community. I shared that with you. I'm not going to really go into it in a lot of detail now. I think it's sort of in the interest of time, but I will tell you it was the foundation to the outpatient treatment, and I have a slide in just a minute. I'll show you that. What parents tell us they're worried about, we've done focus groups, that they'll be judged. If they're a methadone mother, a methadone, they'll be judged by providers, by other people at the methadone clinic, by their family. There's a lack of understanding in those in charge of services that they actually need. WIC, shelters, transportation, whoever's developed a policy for transportation, and there are barriers to frequent hospital visits if the baby's in the hospital. That you say, well, I don't know why this mom is in here. Oh my gosh, you know. And it turns out she has 3 kids at home and she doesn't have anything to do with child care, or Graham was doing it, and Graham was hospitalized because she had pneumonia. So moms are not able to come in. Part of it's just asking. They really worry about birth defects during the pregnancy. They worry about whether the baby's going to be normal. Huge drivers in their concern. They're terrified of losing the baby to DHHS, even though they've done all the right things. They are really worried about knowing how to do the NAS scoring right. I think I shared that with you. And they're feeling that they can never do enough, according to some of the nursing staff. They don't ever get that. Well, you did a good job. That was really good with that scoring. Good job. You're a good mother. They don't hear that. Why? Because we don't think they're good mothers. Because they were in medication-assisted treatment. They did this, or they did that. So you come into the room with that thinking. And so what works well, prenatal groups as a narcotic treatment, they like participating in the research that has to do with infant development. They really value that. They make those appointments. They go out of the way to make those. They actually find that public health nursing in the home, if they know that person, that works well. Main families, gas cards, providers that are very respectful, being listened to and validated concerns. I just have 2 slides on outpatient treatment. We're just ready to kick it off. I thought, are you kidding me? We're going to send these babies out of the hospital, and my gosh, they're going to just abuse those medications. It's 1/1000th of the dose that the mom would be taking. But I've heard people just, oh, these addicts. What are you doing? What are you going to be doing, sending these kids out in the community? Well, the advantages are huge in my mind, and enough that I'm very passionate about moving this out. We have the community support in good shape. The advantage is it supports mom's recovery, empowers the family to care for the newborn, enhances attachment opportunities. This is a real problem for families in the hospital, whose baby's in the hospital, and they can't come in. We have kids that they're scoring on things that have to do with attachment, but I can't isolate out, is this withdrawal that the baby's crying all the time because the nurse can't hold them and no one else can, and the baby's just laying there in the bed crying. Well, they get scored 3 points for that every time the nurse comes in to score them. But is that withdrawal? I don't know that. I don't know what it is. So it becomes very difficult to wean. The other advantage is it frees up acute care inpatient space. Theoretically, decreases costs. I had to put that in there. Decreases costs to the healthcare system. It diminishes a sense of judgment, because real or imagined, because the opportunity isn't there anymore. They're out of the hospital. It changes our care paradigm away from decreasing length of stay for treatment. Now this one is one that I can really relate to. So trying to have a baby on treatment for withdrawal. So trying to every day wean a little bit so we can get the baby out, you begin to sort of tread on that zone of just enough withdrawal we can tolerate, but not too much. Well, I won't wean today, but we will tomorrow, and the baby's a little bit jumpy and stuff. That's not good. That's not good for that baby's brain, nor behaviorally, for that continually to be almost having a little bit more withdrawal. Yeah, but my goal there is I want to get the baby out of the hospital. So decreasing length of a hospital stay unfortunately forces us to find the edge of tolerable withdrawal as we decrease doses. This reinforces poor state control. You know what state control is in babies? It's the ability to stay in a quiet, alert time period. You know the 6 behavioral states for babies?
They better, we just did it yesterday.
All right, so quiet alert is where you learn. If you're in a 5 and a 6 and screaming your head off, you're not learning anything, but how to scream. And if you're sound asleep, that's important. But when you're in that quiet alert state, when you're in a 3 and a 4, that's when babies learn. Babies who have been through withdrawal or that we have go through this process don't know how to stay in a 3 and 4 very well, because most of their life they haven't spent in that time zone. If mom and dad aren't there to reinforce that, you can build on state control by working with babies when they're in that 3 and 4 state. Tactile is probably the most potent one, but also, even if you can't sing, at least humming something to them, whatever. Giving them, I always talk about the 5 senses to parents. So give them sensory input as much as you can in each one of those 5 when they're in that quiet, alert state. Teaching them state control is so important. But if they're home, then they're able to do that. If they're in the hospital and we're continually just, oh my, and that's tolerable withdrawal, but the baby's cranky, fussy, and doesn't get a good state control. Can't be good for the development brain. Moves us away from, we use probably about 20% of the time, I use a second drug to help me wean babies. Outpatient programs rarely, if ever, use a second drug. So it's really a slower process. Well, why do this? To get these babies and families out of the hospital. That's why we push the length of stay short. So why not just focus on that in the first place? So why do I want to decrease length of stay? A lot of the webinars that I listened to, they talk about decreasing length of stay. And it struck me, I said, WTF? Get them out of the hospital and do it as an outpatient. It's a lot harder to do. Disadvantages, decrease in opportunity for assessment and scoring of the newborn. So can I trust the parents to do that? I kind of think I can. I think we pick and choose initially to start off and build success. I think I can do that. It puts methadone in the hands of parents and in the home of someone who is an addict. Oh my God, can I trust the parents? What about the risk of overdose? This is real. What if they give them too much? Will other caregivers be involved and not know how much medication to give, etc.? And what's the risk of the sibling taking the baby's methadone? We're going to use lock boxes, and I think we talk about this a lot. So the other disadvantage, decreased interaction with the family, imposes barriers of transportation, weather, and other demands that can interfere with getting to appointments. It really depends on the community safety net and relies on community resources. And you have the risk of a baby getting lost to follow-up. So those are probably real ones we've been talking about as we begin to do that. So it takes a community. Margie Withers used that comment, and you know, that's not going to work because they don't have the video. Oh well, I had a nice video to end on. So. These are just the people that worked with me. Mark Moran's down here, Margie Withers, Marie Kelly, Sharon, everybody that has helped do this work. So, have a couple minutes for more questions if you want. Yep.
When you talk about teaching the parents about the NSA scoring,
yeah.
And we talked about that time of high emotional period where they're teaching is not going to be effective. When do you start that?
Well, we talked about it prenatally ideally.
Right, that's what I was
Otherwise,
thinking.
it's, the nurse will come in and we'll kind of go through an instruction, and then every 4 hours, they're supposed to come in and review the scoring in that last 4 hour time period. So there's reinforcement each time. Some moms are just, I never do get the scoring right, you know, and they really worry about doing it right because it's so important that they take that baby home.
So when they go home, and if they aren't in an outpatient setting, what's happening? Are they scoring at home and basing? I mean,
That's
the
a good
methadone must
question.
be prescribed at a certain dosage.
I don't have all that paperwork and stuff. The people that, the two people that we've had lengthy meetings with about that have outpatient programs, one made up his own scoring system that included elements from the Finnegan scoring system, and it was either a yes or no. So was it present or not, and every 12 hours. The other one just used discussion with parents. So how's it going? What's happening? What's the baby like? After you've done every 4 hours for 5 days during that observation period, and then if you treat another probably 3 days to stabilize, they're pretty good at knowing the behaviors. I don't know how many of you have ever scored a baby who has withdrawal. Okay, you can't learn to do the scoring on a normal baby. You know, because you're sort of doing stuff in theory. You can only really learn how to do it on a baby who's having withdrawal, and that's what the parents have. Their baby's having withdrawal, so you have, here's what tremors look like, and the baby's sleeping, etc. So by that time period, a hope is that they get it, the scoring. You know. And I actually smile because I have with me trying to make up what scoring system we're going to use. So, yeah.
I want to go back to your genetics comment that you made about the changing with using breast tube DNA of later children. I assume.
Right.
I'd seen a study not too long ago actually that mentioned and it was just on young men who smoked marijuana early on in life into their 20s. It actually changed their DNA.
We're
So
doing that study.
yeah, well,
Yeah,
no,
that's
I
what
don't,
we're
is it the
doing.
same one?
No,
I didn't know
no,
if it
this was like your hardcore
See,
DNA.
now this was just on.
But
on
you're
young
talking
men.
about epigenetics, and that is the expression of the gene. So you have the genes, but then you have another layer of interaction. That's very good. Another layer of interaction that changes the expression of those genes, and that's epigenetics. And we just have a paper we submitted on that, and we're doing another one looking at the epigenetics. So what can change the expression of your genes as you're alive? So your genes can change expression based on what you're talking about, maybe marijuana or other things. And we don't know a lot about what can change that, but that's really kind of like scary.
It increased the
Like you think that, oh yeah, I'm passing on my DNA, but
Right.
what you do also gets passed on in what expresses in your DNA.
Yeah, isn't there a movie of that?
Also,
I don't know the answer to that. No one knows the
because
answer
I mean,
to
it's
that.
also
That's a
on
good
men, not on
question.
women. If you have a man and a woman that have a child that have both smoked marijuana, let's say for 10 years of their younger lives, their DNA has changed, they pass that on to that child. When in time can that be reversed to either become normal again, or does it always stay broken?
There's no answer.
You know what, there are people that
Well, I don't
probably know the
I know you want there to be an answer, but
There are probably people that know the answer to that, but this is stuff that's just come out in probably the last 5-10 years.
Just a quick question, what percentage of the babies that you're dealing with are from this particular region, and
Not
are
very many.
not very many?
There are, I know, Tammy, and I know in the past at Fort Kent, and also probably Caribou, they are treating babies who are exposed. But,
So they're staying local.
because sometimes they'll call when they're having trouble.
So they'll stay local?
But I don't know the answer to that.
They probably don't have funding either, all the way to Bangalore.
Cheryl Cheryl might know, that she runs the old.
Subutex, huh?
No, we are treating babies, but if we have to treat, we're always consulting with you.
Yeah, but I would be a very strong proponent. Moms who are exposed during the pregnancy, who have exposed a baby, they don't want to take that outside the community. They want to, and the more that we can help a community, it takes a community, the more we can help a community do the right thing for those babies. The hardest part is learning how to score. Because people get real nervous about the score because that drives the treatment. But I really would encourage, as much as you can, to keep the babies and the moms here. And the ones that I hate, breaks my heart, is when mom delivers and the baby gets transferred and mom stays behind. So, did that answer your question?
Yeah.
So I don't have the answer, right?
Do you recommend that our prenatal patients on Subutex or Suboxone, which that's what they're on in this area, consult with perinatology?
With you. That they consult with someone here that's knowledgeable, that says, okay, no, to be honest with you, I like our perinatology people. I just got an email that started out with addicted newborn. So you're not talking about someone who's real knowledgeable about this area, because he doesn't do that. They don't do that. They will do the ultrasounds, and they're really good at that. So you want to talk to someone talks with them who can really get across, here's what's going to happen, here's what we expect out of you, and here's what you can expect out of us. I found probably that one of the things that I started doing all this, that was, I thought, probably the most important, was to be credible, was to be accountable for what I said. This is going to happen. I'm responsible to them, and I am credible and reliable, and I treat them with respect. So I'm sure we could make 5 hours out of that or something. Did that answer your question?
Yes, so do you normally take consults from other physicians on?
Be happy to, yeah. It's hard to work it into a schedule, but I'm more than happy.
And most of these patients don't have the resources. to
Well,
make it down
telemedicine.
But that was my next thing, telemedicine.
But the consult has to be what's going to happen here. And
Oh,
I
yeah,
don't-
definitely.
And I don't know what's going to happen here. But I could broker that conversation if someone else is in the room with them, and we could talk through it. I have a whole checklist of everything I cover.
Oh, do you?
Yeah.
That would be great.
Right there, that lady.
Yeah, and then we can send it to you. Those are the ones that we've made up. You know, and that includes that there's judgment's going to happen, and we try not to, etc. Still fall asleep, holding the baby in the bed, safe sleep, and that sort of stuff. And then talk about breastfeeding. There's a whole checklist to go through. Yes.
If someone slowly starts coming off of a substance that has replaced their natural opioids and endorphins, I know that you mentioned that they will sometimes get brain damage with it, but is it still possible for them to regain and replace their natural endorphins through exercise or?
Whatever, yeah.
So
It's a long process. I mean, I've had moms that they're down to 1 milligram of Subutex. I just can't get off that last 1 milligram. But when they came off of it, then they would have their body would have some cravings. But that's what I talk about the damage. It's the damage to the endorphin system that is very difficult to bring back up.
And what is most cost effective or least expensive, the methadone or the Subutex?
I don't know. I don't know the answer. You talk about 30-day supplies and stuff. I don't know. There is a generic buprenorphine now, so it's usually the higher cost as medication that's is not generic. So it's someone who's trying to recover the R&D cost. But Subutex has been out now, and so I think for the last 3 or 4 years, there is a generic, which is usually a lot cheaper. But I don't know the answer. And I know main care woman covers so much, and there's restrictions on that has been a little bit more of a push. But I think, you know, I understand the motivation is really to try to decrease the problem and put pressure on people to get off of the replacement medications, but I think that there's a little bit of lack of understanding of the whole, that it's really a disease. People refer to it as a medical disease like diabetes or whatever. And not to make excuses, but that it may not be able to be cured.
How do you think that, I know a lot of states are attempting to pass laws in which they can either charge or arrest the mother if they're pregnant or their child is born with, going through withdrawal. How do you think that would affect a mother either not seeking help or any medical care at all?
I think it would, yeah, I think it would impact it. There was a Channel 5 had a poll probably last 6 months ago about that very issue. So should we have it make it illegal, essentially, and they used the term addicted babies too. So it just set me off.
Do you think that states will actually be able to go?
There are some states that have probably a little bit more of a, I don't know, more strict.
Yeah, 'cause I know what I had heard was
punitive.
Wisconsin and Florida were trying to
Yeah.
actively make that illegal.
Yeah, and I think you hit on the problem is that you really, I think you decrease engagement. There actually is a guy who has been in the state, Gabor Mate. I don't know, you hear it? Oh, it was great. Yeah. And they have he works in Canada, up in Vancouver, and it's a facility is a observed injection site. So people bring their heroin or whatever and inject it there in case they overdose, then they can be rescued out. So that's one way of thinking about it, because you've got them you've engaged them at some level, and you're trying to make it at least the lifestyle have less risk, so it's a risk-averse behaviors, and trying to make it. Yeah, his book, he's not coming this year, but he was here the last 2 years, and you can look on YouTube, GABORMATE. Really talks about addiction, and the more you can learn about addiction, I think the less you're going to worry about catching it. It's like, homophobia, oh my God, I can't really touch it because I'll catch it. Same thing with addiction. Oh my gosh, I'm going to, but the more you know about it, the more you understand addiction, the better you're going to function as a provider around someone who is addicted. You're going to be more comfortable with it, and you're going to see them for who they are, rather than alcohol in your hands the whole time. There was another question?
There was a question here.
Oh.
Yeah. Is the education always family to family? Do we find support from each other? And I know there's a lot of confidentiality that goes on with it.
That's a good question, and it goes beyond just this topic. The short answer is mothers will seek out other mothers. So we have some moms that are on the floor. Sometimes you get along. We had others that both of them named their baby the same first name, and they got in an argument about who thought of it first. So I'm not kidding. So I think they're going to get along and fine, and I think when that matchup occurs, it can be real healthy. We have an older mom, a younger mom, sort of mentoring her, but it drained the older mom a little bit. So I think when it happens, it's good. I struggle with, can I broker that? Can I make that happen? And I've just learned to stay out of that, even in the NICU. It's a private thing, is what it is. It's an intimacy that you don't always want to violate, and sometimes they don't want to violate it. But it's a very good question, and if you can kind of facilitate it happening, which is what many support groups do and that sort of stuff, or treatment, then I think you can do it. Boy, you got to be skilled to be able to do that. That's a good question.
Do DHHS workers or know some social workers don't understand the whole addictive thing, and they are judgmental, and
Did you
that's
have
not.
to come here today, or did you come here?
Good question.
I came here because it's interesting and a requirement, but
She self-selected.
yes.
She self-selected to come because it was something I want to learn a little bit more about. And I think it's the same thing with DHHS or whatever.
They were invited.
No, but if you want to learn about it, you're going to come and learn.
But shouldn't it be mandatory, especially if you're going to be working with families like this?
Does it mean you're going to learn? You know what, it's a good question. I'm just playing with you, but you know what, you learn when you're ready to learn. We know that with babies in a quiet alert state. They're ready to learn. You know, when we feed preterm babies, they learn how to eat when they're showing eating cues. They don't learn how to eat when you put the bottle in their mouth. I realize that's a very extreme example, but it's the same thing. When people want to learn about that, and these are my clients I'm working with, I'm going to be more effective in my job because I care about the work I do, then you're going to come learn. But if you don't see others as such, you're not going to come. You understand what I mean? If you don't say, this isn't about me, this is about being more effective at the work I've chosen to do. I'm challenging you guys a little bit with
Yeah.
that. All right.
Reflective practice.
I knew that you did, Nate. Are you guys going to take a break? You don't have any more of me today, but that's okay.
Thank you.